Hi, everyone. This is Heart Rhythm TV, and I'm Eliany Mejia, and we are here transmitting live from Barcelona from EHRA 2023. And I have my pleasure to have a great friend and mentor and professor, Luigi Di Biase, with us. Good morning, Luigi. How are you? How are you doing?
Very, very good. Thank you so much. And thank you to you and to IHTV to have me.
Yeah, we had to cover all the good science that we heard yesterday at Barcelona. So let's start by talking about some really good trials that answer a lot of clinical questions. That was the main thing. So let's start about Potter AF study. It's just a big, large registry, a true global trial. We're talking about 35 countries in 5 continents and close to 500,000 patients undergoing atrial fibrillation ablation. And what they did, they just calculated what is the incidence of atrial fistula. And once again, we found that the incidence is actually low, around 0.025%. But interestingly, and something that we probably already know, is that RF ablation was associated with more higher incidence of atrial fistula, 0.038 versus 0.015 for the cryoablation. But one of the points that actually was really difficult and an important point is just the high mortality of this pretty bad complication, close to 90% mortality if we do conservative treatment, versus close to 65 to 70% if we do some sort of invasive treatment. So Luigi, tell me your intakes. You were in the room, you were part of the panel. So tell me, there were your intakes about this really good trial.
Well, we should congratulate the authors for this study, but with all the limitation of a survey where, people participate and the data have limitation, it's incredible that 500,000 patients were enrolled and they have reported the incidence of this dramatic complication. As you said, having a fistula is a problem because there is high mortality if you do conservative approach or if you don't intervene early. So the message is you have to intervene early. Second message is, yes, probably the incidence was higher with RF, but it's also true that RF came into the game earlier than cryo. So I don't know if we repeat this in 20 more years, if the numbers are the same. I think thermal energy source exposed patient to a rare but still fatal possible complication, hopefully changing our energy source from a thermal to a non-thermal, PFA is coming into the game, will probably eliminate, the risk of this very, very horrible complication. So my point is, it's a survey, has some limitation. Maybe many of these fistula are underreported, but the one reported have been well analyzed, and congratulate the author for very, very well done study.
Yeah, so I think that very well done study, a true global one. And once again, the data is consistent. AFib ablation is safe. We can say that, right? It is safe, and 500,000 patients with this. This is the most worried.
Yeah,
and once again,
it is safe, but for an elective procedure to have 1 in a million possibility of dying, it's still a hard pill to swallow for an elective procedure where the patient walks into the lab with his own legs. So I think we really need to go nearly close to zero in order for us to move forward and to, completely increase the indication for this ablation procedure to all patients with atrial fibrillation.
And again, telling us that we have to be aggressive as soon as we diagnose this very bad complication, atrial fistula. We have to go into invasive treatment, right?
Absolutely. And cardiac surgery saved the life of the patient. Anything else will not.
Correct. Thank you, Luigi, for that one. So that was the first one presented. I think that tells a little bit more about reality, what he actually do. Well, the second one we talk about, actually Dr. Jonathan Kalman from Australia. He presented another good trial that answered clinical questions one more time. The impact of catheter ablation timing on atrial fibrillation outcomes. We're talking about a study that enrolled patients with atrial fibrillation, and they compare early ablation, less than 1 month, versus delayed ablation, a delayed atrial fibrillation ablation up to 12 months. And what they found that it was there's no difference between the atrial fibrillation free survival. But important point here is that the group that have a delayed ablation, they also have antiarrhythmic treatment. So what are your thoughts about this trial? What are the key important take home?
I think we have great data that early ablation, meaning that when you compare ablation to medication and look at the progression of atrial fibrillation from paroxysmal to persistent, I think we all know, and we have two data, the attest AFib with RF and the trial by Dr. Andrade with cryo on the same topic, progression of atrial fibrillation. We know that an early ablation will reduce the amount of people that will progress their atrial fibrillation. This trial adds a lot of information in high volume center for when a patient is referred to an EP for an ablation. If you don't have to ablate the patient immediately in the first 2 or 3 months, I would say this trial allow us to say you can wait a year. You still have to do the ablation, but if you have a waiting time of a year, this will not compromise the outcome. It doesn't say that you can delay the procedure forever. It just say that for about a year with medication, you can still have a reasonable good outcome as compared to an early ablation. But I wouldn't like the message to be changing to you can defer the ablation and stay on medication for a long time. The trial does not say that, has not investigated that. And, the paper will be online, European Heart Journal. We can see many more details about that. But it's important to say, once referred to an EP, and you can, wait some time, about a year, before you actually do the procedure without compromising the outcome. That's good news for our waiting list.
Yeah, I think that I really want to emphasize that point, because the other arm, the delayed arm, they actually make a good effort with antiarrhythmic medication. The patients are optimized. So we're talking about we are treating this patient while they're waiting for the atrial fibrillation ablation. So that's a great point that we all want to share and want to make sure that the audience.
Also, for being an Australian study, I wonder they are master of optimization of lifestyle, and probably during this year, patient also had kind of lifestyle modification, losing weight, control the blood pressure, and that's absolutely something that we didn't need this trial to look into, but it's something where we need to recommend to all our patients as well.
That's a good point. Knowing Australian, they did a great job on that, right? And the paper is actually simultaneously published at European Heart Journal. So this is a good data. So let's move on to one of the good trials we were waiting, another good study answering clinical questions that we're already doing. So let's talk about the PowerFast trial. And we have 2 arms of that, the clinical efficacy and safety, and then the sub-study. So we're talking about close to 300 patients that were enrolled to low power, a 25 to 40 guidance by ablation index, versus had high power short duration, 70 watts up to 10 seconds. And we compare those 2 modalities of ablation, once again, from safety, and the other just to see the outcomes. There was more complications. So interestingly, they found actually that there was more subclinical stroke in the patient with high power, short duration arm. So tell me your thoughts, Luigi, about this.
Great trial. I congratulate Dr. Merino for this trial. I mean, high power short duration, he tried to answer to the question, how much is high power. And with the available technology investigated, which was the STSF of the tactical catheter, this trial puts an end to something above 50 watts. I think they investigated 70 watts, and 70 watts did not improve the outcome, while it increased complication. Silent cerebral MRI and some TIA stroke. So in US, we are not even allowed to do more than 50 watts because actually
there's this sun, right?
The stalker or the generator do not allow us to do that. So I would say in Europe it is instead possible. So I say high power short duration above 50 is not recommended. If you use up to 50, a combination of high power and lesion index, either both catheter, one from Abbott, one from Biosense, were utilized. If you do that, you can achieve good outcome. I have to say, we have properly designed catheter for high power short duration. From Biosense website, we have the Q-Dot up to 90 watts in one modality or 50 watts in another modality. Diamond 10 from Medtronic, very good tech. So we have catheter that are designed for it. If you don't want to use this catheter, you use the other catheter. If you do a high power below 50 up to 50 with lesion index, I think you can still achieve good outcome. So the nice information here is don't go above 50 watts because it's unnecessary to achieve the outcome and not having complication. I have to say that I would like to see the outcome of complications sorted by type of catheter, because the two catheter investigators are different. They are not really 3.5 millimeter. One is 3.5, one is 4 millimeter. If you use the same high power and the same irrigation, there is a different density of current that is transmitted. So you may have more stim pops. With more stim pops, you may have more cerebral lesion. So I really feel that above 50 was not safe. And so important information is telling people going above 50 not to do it. So it adds a lot to our, clinical settings.
Yeah. Good point. Good answers. Just, I think that we put in a red flag over, how much, what's to use with the catheters that we currently have. So thank you so much, Luigi. Those are really good trials. I like it. So we're waiting for today, what we can expect for today, late-breaking trials.
Thank you. I will be there on the podium as well. And I hope we have very interesting trial today as well. I'm excited to hear the results. Thank you so much to you and to RHTV for having me from Barcelona. Thank you very much.
Thank you so much, Luigi, and stay tuned for today, late breaking trials. Thank you, everyone.